Great, okay. I just want to thank Sarah Lynn for just all the work that she does in this. And this is a fabulous book, but I am going to take this home because I have lots of students and thought I can hand it on to. So the more the better, and for introducing me to Stephen, so happy to be here. She just told me a few minutes ago that I was going to do this, but she knows that I can talk about sex and gender.
Could you speak up a little, please?
Sure, I will try. So I will just start off reiterating her definitions of what sex and gender mean, and then I just brainstormed 2 examples to portray that, and then I'll tell you about what I do. So as she said, sex is DNA, so XX versus XY, and at fertilization that becomes determined, and then those chromosomes still remain in all of your cells. So it's not just the fact that you may have ovaries or testes, it's that your liver cells and your heart cells still have those chromosomes in there. And we thought that they weren't really doing much once they determined whether you become male or female. So that was one, the first step towards, where we have kind of missed the boat, so to speak. So those chromosomes are still causing, different parts of your body to react in certain ways. Whereas gender is how you present yourself in society. And we know now that it's, the more we learn, we realize how more complicated it is. So it isn't just binary. I'm going to say I'm a female or I'm going to call myself a male. We've learned with the LGBTQI folks that there's a lot of variation along with that. So someone can have the chromosomes of a male or female, yet presents themselves in the opposite way. So they may have certain risks because their chromosomes say XY, but different risks because they're acting as a female in society. So it gets pretty complicated. Where we've kind of lost ground in medicine and health is that we didn't realize that either of those things mattered. And also in research, we considered women to be a subject that needed to be protected. We didn't want women to get pregnant while they're taking a study drug and then have something go wrong. I mean, there's been a few examples of that in the history of things. So both women and men thought it was a good idea to leave women out of the equation. So most of what we've learned, as soon as research started really becoming something that we were getting good at, we created the scientific method, we based it on men, and we ignored sex and gender impact. So I thought of 2 examples that can show you how sex and gender interact in just a normal experience. So the first is the most common that we think of, and we think of, okay, heart attacks. We know actually now over the past 5-10 years that men and women have different heart attacks. And so we're learning that women present differently. So the classic way that men present is crushing chest pain, clutching the chest. We even learned this sign. This has a name, the Levine sign, in medical school. It was a male clutching his chest. So picture a female at home in her house, and she's feeling her typical signs of a heart attack. Short of breath, tired, haven't been feeling right. So she's having her heart attack and she's sitting at home. Now a gender thing is stereotyping, just to create a point. Roles can switch. She's at home and she's like, well, I've got the kids. I've got to pick this one up. How am I supposed to get a babysitter for this other one? I have to make dinner. I'm just going to ignore this. And so we know in research we've proven that women wait longer to call 911. They wait longer for the ambulance. So by the time, a couple of days later, she realizes I should probably call 911. She arrives at the hospital. She arrives in the emergency department, already behind the ball. Now she goes there and she tells the nurse, I haven't been feeling well, I'm short of breath, I'm fatigued. The nurse is like, who knows what that is? Anxiety, GERD. So she sits in the waiting room and waits even longer. Maybe the physician doesn't even recognize that this is a heart attack. So then finally, okay, physicians recognizes this could be a heart attack. Let me order the tests that we do. So there's blood tests that we can do, and there's other diagnostic tests to determine whether she's having a heart attack. Well, it turns out that because this female has XX in her chromosomes, her arteries that supply the heart don't have a heart attack the same way that an XY arteries have a heart attack. So men classically have a large obstruction in their artery. That's why they get that quick chest pain. Women tend to have smaller vessel disease. So it's not the big blockage, it's the little inflammatory reaction or spasm that's happening in those. So our blood tests aren't as good at determining that. The cardiac catheterization, or when they squirt dye in to look to see, they're not the right tests. And so this woman, you know, she may get admitted to the hospital, she may eventually be diagnosed with a heart attack, but even our blood tests and the way that we diagnose it aren't taking her sex into account. So we know that women do worse off after having a heart attack. They have a higher mortality than men. 6 months down the line, years down the line, they're more likely to have a second heart attack than men. So it's a really bad situation for women, because it's not just the fact that, you know, she may wait longer. There could be gender bias. The gender bias is maybe on the physician part, that she's just having anxiety. So you see how all these components kind of come into play, where sex comes into play, where gender comes into play. I thought of another example for men. Speaking of transportation and trauma, men have more traumatic injuries than women across the age group, until maybe elderly. And that may be related to that women live longer. So men have a lot of death and injury, morbidity, mortality due to injury. That could be due to the fact that their gender roles put them at more high-risk situations. They're up on ladders, they're doing construction with all of these large heavy machinery. They're putting themselves at higher risk, they do contact sports. So they, because of all this, are doing high risk. So if they actually present to the emergency department after they have that injury, they actually do worse than women. And it has to do with testosterone. Because men have testosterone, testosterone is an anti-inflammatory. So if men actually are in the hospital because of a brain injury or a broken leg, their testosterone, because it's anti-inflammatory, they're more likely to get hospital-induced infections. So they die of sepsis when they're in the hospital for their broken leg. So there's lots of, there's a million different examples. What I do in my division is we study these. So we have 3 things that we concentrate on. We concentrate on research. So we research conditions that have high public health significance. Emergency departments see on an average of 120 million patients a year. And there's no evidence that this number has peaked. So emergency medicine is a lot of people's primary care. It's their, it's their go-to. So they are coming when they're involved in, their crisis, whether it's a cold or their heart attacks. And so we do research on stroke and sepsis and alcohol and substance use and heart attacks. And then we have an educational program. We have electives for residents, and then we have a 2-year fellowship. So we now have fellows that have come and do 2 years extra to their residency to learn how to be experts at this in emergency medicine, which is really remarkable. It's the first in the country to have a division that does this sort of thing. And the other thing we do is advocacy, because as we're showing that the awareness of this has to increase globally. And so we're involved with many programs. Locally, we have a community advisory board. We do national things with our national organization. Last week we were involved in teaching deans of medical schools, how to incorporate this into their education. We also have programs for the patients. We have these posters in the, all across the emergency department that teach patients from both the male perspective and the female perspective something about their presentation or treatment. And our goal is, yes, to educate the patient. Then we want the patient to leave, and when they follow up with their cardiologist or their primary care doctor, to ask them, hey, by the way, that prescription that you're writing, is that specific to me because I'm a female? And then that physician may not know, and they go look it up, and we're trying to disseminate this kind of from the patient point of view. The patient can be their own advocate. And so I also speak nationally on this, and I was involved in a TED Talk that I did just under a year ago or so, and just last week was actually picked up by...
That's what I saw.
When you said that, I was almost going to say something. I was like, did you see me on TV?
In fact, it's loaded on my computer right now.
Wow.
I was actually looking at that material just when, I'm sorry for interrupting, but when I was planning some issues with Sarah Lynn for her trip here, I had received the emails from Ted, and so I had your video up. That's what I said.
That's really great. In 1 week, it had over 300,000 views. So TED.com is a global, I'm getting email, really, I'm just getting emails from France and Russia and Sweden. Patients are sharing stories of how sex or gender has impacted them. So it's been really remarkable.
Who was it picked up by?
TED.com, so they made TED.
They don't always pick it up, but in this case they did.
Exactly, so there's lots of local things, and if it's something that gets a lot of traction, they'll pick it up. So they picked it up and put it on their main page and kind of promoted it through their website. So